Good afternoon, everybody. Good afternoon, everybody. Reed here. Today, today we're going to go through mood stabilizers, and we'll go and look at the mechanism action of mood stabilizers. You know, mood stabilizers are very important. You know, um, and we're talking about moods such as depression, things like mania, or mixed episode. So it's possible to have depressive episodes, manic episodes, and like mixed episodes. And um, um, with depression, you don't have to feel only sad to meet the diagnosis of depression. Irritableness can also be a symptom of depression. Um, and in fact, I think I see people, my patients, presenting more with irritableness as the major component of their mood disorder as opposed to just sadness. But yeah, so mood disorders are very important. Major depressive disorders, bipolar disorders, cyclothymic disorders, and dysthymia also. So I have here. Um, Let me go ahead and okay, let me go ahead and just search, explain. So we're going to look at the non antipsychotic mood stabilizers because, of course, the atypical antipsychotics like Seroquel, Risperdal, and all of them, they have an indication for bipolar disorder. But let's just look at the classic mood stabilizers like Depakote and lithium, right? So here they have lithium right here, anticonvulsants, great. And then we have the atypical antipsychotics down here, Seroquel, Risperdal, Abilify. And remember the difference between those typical antipsychotics is the typical antipsychotics are more potent and they more specific for the D2 receptor. And this atypical set of antipsychotics, they target other receptors, serotonin, norepinephrine, and that's probably why they also effective at treating mood disorders too. So here we have Seroquel and Risperdal and Abilify here, but some have mood stabilizing effects as well. Okay, but let's look at these main two. Here, lithium, which is primarily an anti-manic agent, and the anticonvulsants such as Depakote, Lamictal, Tegretol, Trileptal, and mainly let's look at Depakote and lithium. I mainly use Depakote for the depressed and mixed episode. If a patient continues to have these depressive manics or mixed episodes just continuously, like every month, it could be a process of rapid cycling. And so you want to make sure you put the Depakote with lithium if you're suspecting that they're rapid cycling. And I sort of look at the Depakote for the lows and mixed episode, and the lithium for the highs. Lithium is a salt here, it's an element. So lithium is a naturally occurrent element, right? It's effective in treating both manic and depressive episodes. It works by affecting the flow of sodium through nerves and muscle cells to help stabilize mood. We're gonna see that mechanism later. Blood tests are necessary to monitor lithium. Lithium has that narrow therapeutic range. If it's a little bit too much, it becomes toxic and start to impact the kidneys. If it's too low, it may not have any clinical effect at all. So you have to get a blood level with lithium. Works very well. Okay, and look here, anticonvulsants. Okay, these medications are originally developed for seizures, but also have mood stabilizing effects. Valproic acid, Depakote, effective for rapid cycling disorders and mixed episodes. And so let's look at the lithium and Depakote as our main mood stabilizers. Depakote also has that therapeutic range, neurotherapeutic range too. If it's too low, it's not going to have any much of a clinical effect. If it's too high, you get the Depakote toxicity. And we were concerned about the elevated liver enzymes in the face of Depakote and the possible hepatotoxicity it can cause. So with Depakote, you definitely want to check a Depakote level, and then you want to check the liver enzymes to make sure everything is going okay. All right, so let me look at, but there's something interesting about lithium and Depakote. Let me see if it'll go into it here. Now, let me see if it'll get into detail. Lithium and Depakote have two very important properties. Both of them result in down regulation of glutamate receptors, and it results in upregulation of GABA receptors. And so we want to change that excessive glutamatergic activity. So we're going to download those receptors and start increasing the GABA receptors so we can sort of keep the system in balance there. So the lithium and Depakote cause a down regulation of those glutamate receptors. And that's what you want. Remember, in the case of bipolar or mixed and manic episodes, we're concerned about the combativeness, the agitation, the aggressiveness, and things like that. And so we definitely want these medications on board. Okay, lithium is widely used as the effective mood stabilizer, particularly for bipolar disorders, considered first-line treatment, especially for preventing manic episodes and reducing the severity and frequency of mood swings. Yep. The exact mechanism of action is not fully understood, but it is believed to act in the central nervous system by balancing certain substances in the brain that regulate mood, behavior, thoughts, and it may influence neurotransmitters like serotonin and dopamine. Let me look into it a little bit closer. It may say it. Okay. It's for bipolar disorder, off-label use. What is it? Major depressive disorder. Often, lithium may also be prescribed off-label condition for major depressive disorder, and is often augmented therapy with antidepressant managing bipolar disorder. I'm sure lithium is a really good augmenting agent. Okay, dosage. Lithium comes in various forms, including capsule, tablets, extended release, and solutions. Great. Capsule, tablet, extended release, and solutions. Okay. Side effects. Kidney damage. Thyroid. So remember the renal insufficiency, the kidney issues, and then the hypothyroidism in the thyroid. Lithium toxicity can induce nausea, vomiting, trembling. Yeah, blood monitor interaction, hydraulic effects. Okay, let's see. Let me specifically look for the mechanism of action for lithium. Okay. You asked for it. Okay, lithium's mechanism of action in treating bipolar disorder is complex and not fully understood. Okay. Okay, I think this can be seen better here. Okay. Okay, here's the breakdown. Here's the breakdown. Okay, glutamate. Lithium actually stimulates NMDA receptors increasing glutamate availability. However, chronic administration leads to NMDA downregulation and modulating glutamate neurotransmitter. It also has a dual effect on glutamate receptors, keeping glutamate levels stable. I didn't know initially it stimulates the receptor, then it leads to a downregulation of the receptor. Yeah. And when I think about using lithium in the manic state, that's exactly what we want. We want to downregulate the receptors. We want to downregulate those receptors. Okay, let me see here. Okay, on monoamines. Okay, lithium can affect both serotonin and dopamine. It may increase serotonin transmission through various mechanisms, potentially contributing to the anti-suicidal and anti-aggressive actions. It also been suggested to inhibit increased dopaminergic activity, potentially contribute to the anti-manic effects. So it also affects, and I'm just now paying attention to this, so I didn't even realize it had that much of an interaction with both serotonin and dopamine. Okay. So the intracellular pathway, okay, the PIP pathway, phosphatidylinositol pathway. Lithium inhibits the inositol monophosphate phosphatase enzyme in the PI pathway cycle. This disruption can affect neurotransmission mediated by the PI system, impacting mood regulation. Okay, so basically this phosphatidylinositol monophosphate pathway here affects that glycogen synthase. Okay, lithium inhibits glycogen synthase kinase, which is involved in various cellular processes like cell survival, neuroplasticity, and apoptosis. By inhibiting glycogen synthase kinase, lithium may exert neuroprotective effects and contribute to mood stabilization. Okay, phosphatidylinositol and glycosylphosphate, CAMP. Lithium can also affect the cyclic AMP second emission signature, which is involved in cellular response to neurotransmitters. Wow. It may influence the production of neurotransmitter factors such as BCL2 and B, brain-derived neurotropic factor. Okay, wow, interesting. Okay, neurotropic effects. Yeah, reduce oxidative stress, increase oxidative stress. Yep. Lithium sort of have like a neuroprotective effect. And, whenever I have patients with what I'm concerned about, impulsivity, impulsivity and things, I make sure I reach for lithium first because it can be very, very helpful in decreasing the thoughts of suicidal ideations and also in decreasing the unpredictable behavior and impulsive behavior. So lithium is very good for that. Other effects, ion homeostasis. Okay, lithium can displace intracellular sodium, reestablish the sodium electrochemical gradient. Okay. Neuroplasticity. By affecting the various intracellular pathway, lithium can promote neuroplastic changes, which are important for mood stabilization and long-term treatment effects. It's very interesting with lithium. And let me just go through some of the, explain the, let me see, adverse. Yeah, first, so we want to go through, because remember, we don't want to give it in pregnancy. So let me just go through this real quick. It has a narrow therapeutic index, meaning the difference between the effective dose and potentially toxic dose is small. Be careful monitoring. Okay, neurologic tremors, drowsiness, GI, nausea, dry mouth, great. Renal, increased thirst, polydipsia, polyuria. Up to 70% of long-term lithium users may experience excessive thirst and urination. Up to 70%. This is due to lithium's effect on the kidneys, interfering with the kidney's ability to conserve water. Increased thirst, polydipsia. Long-term, other weight gain, substantial portion of individuals taking lithium may experience weight gain. I haven't experienced that often. I don't really experience the patient gaining weight on lithium. Hair loss, I have experienced patients describing that in lithium. Okay. Toxicity, this is a serious narrow therapeutic window. Toxicity can be a sudden, chronic. Symptoms range from mild to severe: blurry vision, seizures, dehydration, serotonin syndrome, thyroid problems. Long-term lithium use can affect thyroid function, leading to hypothyroidism or underactive hypothyroid, or less commonly, hyperthyroidism. So yeah, watch the thyroid, kidney. Prolonged lithium can cause, especially in high doses or with repeated toxicity exposures, can lead to kidney damage and impaired renal function. Regular renal function is crucial. So we want to, especially at high doses with repeated toxicity episodes can lead to kidney damage and impaired renal function. So you have to make sure that you don't hit them get too high with the lithium. Heart problems. Lithium causes mild reversible change in the heart rhythm. Yeah, it can interfere with it. It can cause that heart prolongation at QTC interval. Cognitive impairment. Some individuals may experience cognitive effects and mental slowing, things like that. So, so you can see the side effects of adverse effects of lithium. And let me say, adverse lithium in pregnancy. Yep, Epstein anomaly, right? Lithium during pregnancy increase the risk of birth defects, especially cardiac malformations like Epstein anomaly, can lead to adverse outcomes such as premature birth, low weight, and neonatal disease. I think the Epstein anomaly is that bicuspid mitral valve. Correct me if I'm not. It's been a while, so look at this. So we're worried about that Epstein anomaly here. Okay, so I think we got that here. Next, let me look at the okay, let me see the mechanism after Depakote. So we looked at lithium, manic episodes, Epstein anomaly, cardiac hypothyroidism, that cardiac block, renal insufficiencies, renal issues, not able to concentrate the urine. The renal issues come about with repeated overexposure to toxic levels of lithium. Downregulate, basically inhibits NMDA and results in downregulation of GABA, downregulation of glutamate receptors. On this study, I didn't see them talk about the upregulation of GABA. So you can see how all of that narrow therapeutic window, and you can see about how very lithium is a very useful medication, and it's a salt. It's an element. So you should always think about that when you start seeing about treating long-term agitation, combativeness, and aggressiveness, things like that. So let me look at Depakote, the second mood stabilizer. Depakote, the brand name for valproate sodium, works through several mechanisms to stabilize nerve activity and prevent abnormal electrical impulses in the brain. Its therapeutic effect comes from the combination of actions that are not yet fully understood. Primary mechanism of action enhances GABA activity. Remember, there's two main neurotransmitters in the body, and these two neurotransmitters are present throughout all the tissue. Glutamate, which is excitatory, and GABA, which is inhibitory. When we see patients have difficulties with some of these disorders, we see the lack of inhibition. We see the brakes failing. And because the brakes fail, the networks become overactive, and we see the overexpression of glutamate. And so now you see the host agitated, combative, aggressive. And so somehow we're going to need to balance that system with another medication by targeting the other receptor that's present throughout the entire organism, and that's GABA. We try to enhance GABA activity right away by giving benzodiazepines. So here, the primary mechanism of action enhances GABA activity for Depakote. This is considered one of Depakote's main actions, right? It increases the amount of GABA, the brain's chief inhibitory neuron, right? By inhibiting the enzymes that breaks it down. Okay, so I didn't know. You learn something new every day. Remember that new day. So it inhibits and activates the enzyme that breaks it down. An enzyme. This raises the level of GABA, which calms and relaxes nerve cells. I thought it had more to do with uploading the GABA receptors as opposed to turning off the enzyme that degrades it. Like acetylcholine in that synaptic cleft. The acetylcholinesterase, it targets the acetylcholine and breaks it down. But I never realized Depakote worked with same enzymes that metabolize GABA. Okay, here. So next, blocking ion-gated sodium channels. It's an anti-seizure. Depakote is an anti-seizure medication, right? Depakote blocks the entry of sodium into the neuron, which reduces the excitability and firing rate. Hey, so it increases GABA by deactivating the enzyme that breaks down GABA, and then it blocks the sodium gate. It makes the neurons less reactive. This helps prevent a rapid, repetitive firing of the neuron that is characteristic of seizures. This is great, right? Inhibiting T-type calcium channels. T-type? T-type? T, how do you get all the way to T? Do you start from A? The drug blocks certain calcium channels, which are involved in the generation of abnormal electrical activity in the brain. This is especially important for treating absence seizures and conditions linked to those channels. Okay, yeah, so increase GABA activity by deactivating the enzyme that breaks it down, blocking the sodium channels to decrease polarization, to decrease the excitability of the cell, and then blocking specific type of T calcium channels. And I'm sure that decreasing the gradient there will actually make those channels less sensitive and decrease. That's the mechanism of decreasing the seizure-like activity. Okay, it's very interesting. Okay, other potential mechanisms. I'm not sure if I want to go into those. Therapeutic effects explained. Okay, epilepsy by inhibiting sodium-calcium channels. Yep. Also, enhancing calming GABA symptoms, increasing inhibitory tone. Yep. Depakote prevents uncontrollable electrical bursts that cause seizures. This AI thing is really amazing because reading, it seems like reading this stuff now, it seems like it's so simple. It seems like it tells you everything in such everyday language. Okay, next, bipolar disorder. Its ability to stabilize neuronal firing and influence gene expression contributes to its effectiveness as a mood stabilizer, managing manic and mixed episodes, which may reflect overexcitation or excitability of the neuron. So that makes sense. Depakote would turn the enzyme off that degrades GABA and increase GABA's tone that way, shuts off the calcium channels and also stabilizes the sodium channels. Makes sense. Migraine prophylaxis. The various pathways it influences in the brain help prevent the abnormal neuronal activity it is thought to trigger in the head. Okay, that's great. So that's the mechanism of from Depakote. Let me see. What are the adverse Explain the adverse reactions to Depakote. Yeah, let me look at some of these. Okay, let's see here. It's used to treat seizures, bipolar mania, migraines. Okay, like GI issues, neural issues, hair loss. We got those. Okay, here, liver damage. All right. And so we're concerned about the hepatotoxicity, pancreatitis, right? Now, we don't want to give it in pregnancy because of the risk of neural tube defects right here. And what is that called? A neural tube defect, spinal bifida. Okay, heart abnormalities, which is Epstein, that could be Epstein abnormalities, decreased cognitive effects during pregnancy. Look, suicidal thoughts and behaviors. Okay, bleeding problems, thrombocytosis. Yep. High ammonia levels can cause encephalopathy, right? Severe skin reactions. Now, there's another thing. They also have it down here. Depakote is also classified as it causes cancer. They use it to produce certain type of tumors, predictable tumors in lab animals. And so it's also used for those purposes. But let me look that up too. I don't want to just say it like that. Let me look it up. But here, yeah. So let's just look through here. So remember, we had several clients today. We have to look at liver enzymes. If liver enzymes are elevated, and you don't want to get into that story. You want to choose something else that's not metabolized by the liver, to go around the liver. If you have patients with liver damage, you don't want to use Depakote. Pancreatitis, you don't want to use in pregnancy because the risk of spinal bifida. You have to watch out for agranulocytosis, have to check ammonia level. And the ammonia level could be sort of like an indication that the person is having more of an altered mental status. In the medical world, they'll call that a metabolic encephalopathy. And psychiatry will call this a altered mental status, and also a delirium, whether or not it's going to be a hyperactive delirium or a hypoactive delirium. So, so this encephalopathy could be a result of elevated ammonia levels in patients on Depakote. Okay. So we want to consider the elderly and things like that when you use them. Okay. So I did the mechanism, the adverse effects. I think that's it. I don't think it's 27 minutes now. I don't want to go too long for this, and maybe I should be able to answer a few questions. Okay, guys, so let me see if I can take a few questions, if you may have a few questions. Okay, so let me see here. Okay. Hey, buddy, how's it going? Good to see you, Doc. Good to see you, buddy. What are mood stabilizers, and how do they differ from antidepressants and antipsychotics? Remember, the antipsychotics, the atypical antipsychotics also target dopamine, serotonin, norepinephrine, and things like that. And so they can be very effective in treating the mood disorders like bipolar. So many of them, like Seroquel, Risperdal, Abilify, already have the indication for treating bipolar disorders. And I would go with those first if you're in an outpatient setting. But on the inpatient setting, when the symptoms are more concrete and very persistent and very, you're concerned, then you want to go with the mood stabilizers like Depakote and lithium. We just reviewed the subjects of antidepressants yesterday, and we basically discussed how they block the reuptake, the selective. They block the reuptake inhibitor pump, therefore increasing the amount of serotonin and norepinephrine in the synaptic cleft, and therefore increasing the transmission of those serotonergic and norepinephrine networks. So the mechanisms are basically still the same, but different molecules interacting with the same type of structures. Mm-hmm. Hey, Umber, how's it going, buddy? Do mood stabilizers have a role in preventing neurodegeneration? It'll be hard to prevent neurodegeneration, but all of this activity could result in the point in the production of brain-derived neurotropic factor. And I think that's where you're going to get the neuroplasticity. That's where you'll get the learning and things like that. Preventing neurodegeneration is things like I would call someone who's not living up to their capabilities or withering away. You know, great. Okay, Dr. Liv, correct. Epstein, it affects the tricuspid valves. Thank you so much. So it's a tricuspid valve, not a bicuspid valve? Correct me, let me know. Thank you so much. Mohammed, how you going, buddy? Appreciated this. Medical and coding knowledge, keep supporting. Thanks, buddy. iHash, how you going, buddy? What's the main challenge in prescribing and monitoring mood stabilizers? Getting a blood draw, the administrative structure that's involved in managing the care around this. Sometimes the clients may not have the cognitive ability to manage the appointments, to remember the labs, to attend the lab appointments, to have resources. And these are a lot of complicated things for people to do. The getting labs and following up with the treatment is a challenge. That's why you don't have to get the blood draws with the atypical antipsychotics, right? And the atypical antipsychotics are not really associated with the same side effects like Depakote, hepatotoxicity, agranulocytosis, and things like that as side effects. And for lithium, kidney problems and thyroid problems as side effects, whereas with atypical, they're classified as antipsychotics, but you don't have to get all the blood draws or all the administrative work that goes along with them. So I would go with a atypical antipsychotic first for these disorders, and then use the mood stabilizers when it gets really intense, when you need some backup. Okay, great. Okay, Ms. Watts, since lithium and Depakote are not used for every episode of excitability across all diagnoses, I am curious to know the brain chemistries during mania to see if it correlates with the sodium-calcium channels. Think about this. The mania increased glutamatergic activity. Somehow the threshold of an action potential being lowered, and the network is just on overdrive. That's what I would probably anticipate is happening down there at the molecular level. It's an interesting story to try and explain this at the molecular level. It'll be a very interesting story. Okay, so right now we're at the 32-minute mark. I didn't want to go too long. I want to try to limit these talks to 20 minutes. Went over. But it's a pleasure doing these. Let me know if you want me to cover certain topics. Either in the chat, just let me know, and I'll stay on those topics. I wanted these sessions to be very helpful for my patients, for their families, and then for the students who are learning. So if you want to give me any input on these, I'll be glad to take it. But I'm trying to keep it 20 minutes. And I'm trying to keep the language in everyday terms so it can be approachable to my patients and their families. Okay. So it's a pleasure talking to you guys. Read out. I'll talk to you guys later. Take care, guys. Read out.